FAIF recognizes the consequences to business and the business community in terms of the lack of a healthy workforce, the cost drivers, and often perverse incentives in the current system. And so a healthy workforce with cost efficiencies in the system, with outcomes-based rewards, is something we think is an absolute requisite for Florida to have in order to do prosperous future economic development, provide jobs, which is what AIF's mission is all about. And our view is that the underinsured or the uninsured place a burden on all of us, including Florida's businesses, that simply must be addressed in one fashion or another. Working out the complicated nuances between state policy and federal policy has become a significant challenge. And the hospitals, the folks trying to seek care, and businesses themselves are the ones that are increasingly put in the middle of finding ways to solve policy differences between Washington policymakers and our Florida policymakers. Eliot Fishman is here with us today. He essentially runs the Children and Adults Health Care programs for CMS. He's with the Center for Medicaid and CHIP. He has been published extensively on how healthcare policy, healthcare plans, and Medicaid reform can be improved throughout the United States. He was a principal in his former life at Health Management Associates, a healthcare analysis and consulting group. He's been vice president of the Metropolitan Jewish Health System in New York. He's got a degree from both Harvard and a PhD from Yale, and we give a hearty Florida welcome to Eliot Fishman. Thank you for being with us today.
Aside from the millions of people who will be affected by the things that I'm going to talk about today, within Florida, really, as is often true in the world of policy and politics in the United States, the nation's eyes are on Florida. So we all bear a real responsibility for what happens next in the state of Florida. Tom mentioned that I'm responsible for the Children and Adults group within CMS. You might think that Children and Adults doesn't rule out very much. And more specifically, we're responsible for eligibility and enrollment policy, for quality improvement, for waivers, which is something that has become an important part of the conversation as we talk with states about expanding coverage, and for the Children's Health Insurance Program. And that's all within the Center for Medicaid and CHIP Services. So today, I'm going to ask you to think about Medicaid in perhaps a different way than you're used to thinking about it, to think about the problem of the uninsured and of coverage in a clearer way, and to conclude by thinking realistically about what Florida's options are going forward. So first, in terms of thinking about Medicaid, Medicaid is now the largest health insurance program in the United States. We're covering almost 70 million people with full coverage. In addition, we cover 20% of Medicare beneficiaries with supplemental coverage and with long-term care, the most important source by far of long-term care coverage. Medicaid is a big part not only of our healthcare system, but it is a big part of our economy. And that is something that I think we collectively have not totally absorbed into thinking about decision-making about both the scope of Medicaid coverage and in terms of how Medicaid payment works, that it's really increasingly a driver of everything else in the healthcare system. So now I want to talk about the problem of the uninsured as a public health issue. We talk about, and it's very important to talk about, coverage as a matter of economic impacts, a matter of the state of Florida retaining the money that it is paying in through its federal taxpayers into the Medicaid system. We talk about impacts on the healthcare system and stabilizing the healthcare system. Those are all critical, important conversations. But none of us should forget that people with insurance use healthcare differently. People have a serious health problem. It's diagnosed sooner if they have coverage. If people have a chronic condition, they take their medications better. They take better care of themselves. People with health insurance get their mammograms on time. They get their colonoscopies on time. It's just a different world of health, of individual level health, and ultimately of individual level mortality when people have health insurance coverage. And none of us should ever for a moment forget the sacred obligations that really puts on us when we're talking about what the future is of the uninsured. And the problem of, the scope of the problem of the uninsured is different in this part of the country. It is more severe in this part of the country. This takes a look at the South as a region as a whole, and note that it is the highest region in terms of the rate of uninsurance. Looking in a somewhat more granular way, so dark blue is a higher rate of uninsured. And note that much of the state of Florida is the darkest shade of blue here, which means that more than 1 in 4 non-elderly people does not have health insurance. Not coincidentally, so I think these statistics are very closely related to the statistics on lack of insurance coverage. The Southeast has, by a significant margin, the highest share of individuals who report fair or poor health status, and this is consistently the case. So this part of the United States is an outlier. This is in terms of self-reported health status. If you look at the more medical claims-based measures of emergency room visits, so some of these differences are very stark. You look at the left at emergency room visits for pulmonary heart disease. This part of the country has ER visits that are 2 to 3 times as high as they are for the West and for the Northeast. And if you think about ER visits, that's both a measure of people's underlying health, but it's also a measure of how good their access is to regular care outside of the ER, right? So these are not subtle differences, and they reflect real suffering and ultimately real mortality that is taking place at a population level scale, but is also affecting individuals and households around the state. So this is a map of where we are today in terms of states that have adopted the expansion of eligibility to adults up to 133% of the federal poverty level. Most of those adults are working, this is what is sometimes referred to as the coverage gap. That is, people who are not eligible for subsidies on the exchanges and who need if they are going to be covered, for states to adopt the expansion. This is 28 states in the District of Columbia. We at CMS tend to count DC as a state, so we would say 29 out of 51. That number has been growing steadily, but note the regional distribution. So we have really one state in the South that has expanded. They did it their own way, and that's Arkansas. I'm going to spend a bit talking about what the impact has been in Arkansas. Arkansas did its expansion via purchase of private coverage in the individual market, calling it the private option. And just over the course of 2014, so this is in less than a year of adopting this expansion, the number of uninsured patients who visited the emergency department was down 24%, and the number who required hospitalization was down 30%. Right? So those are numbers, you're talking about really dramatic, historic reductions in that kind of utilization that certainly in my field, in healthcare policy, it's really revolutionary. Arkansas Hospital Association surveyed Arkansas hospitals, so this is going back to economic impacts, and their losses decreased by almost $70 million. Again, this is over the course of part of 1 year. Admissions for the uninsured in that survey were down by almost half. Just taking a look at what Arkansas did. They were able to use qualified health plans in the marketplace. They were able to deliver the benefit package that is required by the ACA through those qualified health plans. I think the main message that I would give here is that there is a lot of flexibility on the federal side in terms of what works for a state and what the needs of that state are. I would say in the case of Arkansas that we are really eager to see how this works out for them. So this is other demonstrations that we have recently partnered with states tied to the expansion of coverage. And when this says 1115 demonstrations, that's the authority that we have to waive federal law or federal regulation in many areas of Medicaid law and regulation to promote the goals of the Medicaid program. And we have been very intensively involved with states looking at these flexibilities. So Indiana, the Healthy Indiana Plan 2.0 was our most recent program. That was worked out with the administration of Governor Mike Pence in Indiana. I would note that Governor Pence is a movement conservative, was part of the Republican House leadership. You know, he has some friends at this table. And all of these states that are listed here involved Republican governors and, for the most part, Republican state legislatures. We've also done, without any demonstration authority, we've expanded coverage with Republican governors in Ohio, Nevada, New Mexico, New Jersey, Arizona, based on their existing Medicaid programs. Put these together, that's a lot of big states, and we have found a way to get there. So this is just to describe the scope of the problem, and 34% of eligibility for parents which puts it down near the bottom of eligibility for parents and at 0% for other adults. That's prior to the Affordable Care Act. In most states, there's different eligibility for parents and childless adults. The ACA option evens that out and brings eligibility up to the point where subsidies kick in for marketplace coverage. So Florida starts with a bigger gap than other states have, including some other neighboring states. If you're able to look here, Florida trails Georgia, North Carolina, South Carolina in terms of eligibility for parents. So I'm going to transition now to talk about changes that are taking place in the Medicaid program, starting with a focus on our reporting of quality of care in the Medicaid program. And this is by way of communicating that we really are in a new era of accountability for outcomes at both the state and federal level. I think that's important not only as part of the conversation around expanding coverage and the difference that Medicaid can make, but it's also important for you as stakeholders in Florida's healthcare system to know that this data is available and to be aware of our collective ability to start monitoring actually how care is being delivered in the state. We started to collect measures across the states on care of children a few years ago. We've now started to collect for adults as well. We put this out every year in an annual report to Congress. And our hope is that states are going to use these numbers to drive quality improvement. We're certainly keeping an eye on them, but you all should be as well. So these are the areas that I'm going to just give a quick overview on. Let's see how I'm doing here on time. Okay. I think what you'll see is that, just looking at Florida, that the state is doing pretty well in some areas, but that there are other areas in which there's a clear need for improvement. So this is rates of well visits for children. Those of you with teenagers will perhaps not be surprised that there is more variation and that it's tougher to get adolescents in. We are doing pretty well with younger kids, and these numbers really look pretty good next to numbers for commercial coverage. Looking at a state-by-state level, so Florida is just under the average for infants. This is children 15 months or younger getting 6 visits. There's certainly room for improvement there, but Florida's close to the national average. And just above the average when you look at teenagers, an area where we have a lot of work to do nationally. So dental is an area where we have a lot of work to do in Florida. We've been looking at the percentage receiving a preventive dental service and the percentage receiving a dental treatment service. And nationally, we have gone from a low base in Medicaid in terms of children who received any preventive dental service in a given year, but we have been steadily improving. Florida is well under the national average. You look at Florida, you do not want to be dark blue in these maps. The good news is that I think ACA is focused on this problem. We are working closely with ACA on it, but if you think about what dental care means for a kid, what dental care means for childhood dental care means for an adult in terms of lifelong impacts, not just in terms of health, but in terms of appearance and socioeconomic kinds of impacts, this is really critical. And then I would note, to get back to my first theme, that in all of these cases, we're only talking about people who have coverage, right? And you can't even start these kinds of conversations if people don't have insurance. This shows parents' assessments of getting care for their kids. We do well in terms of basic care. It's more of a challenge in terms of getting appointments with specialists, although I would note that getting appointments with specialists can be tough with any source of insurance. But still, this is something that we're tracking and looking at ways to improve. So this, I think, of all the slides in terms of our quality numbers, this is one that I would hope that you retain the most. This compares performance in Medicaid with median performance in commercial health plans, so employer coverage and other sources of commercial health care. And just note how similar these are in general across the board. These are very comparable numbers. Medicaid, in terms of core access to care, is a really important source of health insurance. And I would ask you, don't ever believe that Medicaid coverage does not make a difference in terms of people's access to care. We're talking about something that has the potential to very fundamentally change how people are accessing health care in the state of Florida. So now I'm going to move on to a subject that is, I know, of great interest here today, which is payment reform in Florida. And I'm going to be saving my specific remarks on next steps around payment reform in Florida for the end, which I know is of enormous interest to you, as it should be. I'm just going to give a bit of national context. This is a big push at the federal and state level. Getting payment right is really one of three fronts that there has been a lot of work under the Obama administration and really going back to the Bush administration around changing healthcare delivery. They really all have to move together in terms of changing the way that healthcare is paid for, changing the way providers are organized to support more integrated care delivery, and then having the data, and particularly the data on care quality, to drive ongoing change and improvement at the healthcare system level. There's a lot going on at the Medicaid level. So the Health Homes program tries to develop specialized medical homes for people with specific chronic conditions. We have 24 programs set up in 15 states. We have funding pools in a small number of states that are tied to delivery system reform. That's something I'd be happy to speak about in more detail in the Q&A if you're interested in. We have several states that have started shared savings programs that's separate from managed care. A lot of states are doing integrated care models via managed care models, including primary care case management fees, which is a kind of a special Medicaid thing. Florida's had its experience with PCCM and has gone to managed care. And there's a lot of collaboration going on around Medicare, Medicaid dual eligibles and the new Center for Medicare and Medicaid Innovation. There's just a lot of ferment in the area of payment reform, and it has been hard to even start that conversation with Florida with what is an archaic and irrational existing payment system around particularly hospital services in Medicaid. Those changes in payment have again led to really dramatic revolutionary changes in actual utilization. So early elective deliveries, this is elective C-sections for pregnant women before 39 weeks are down dramatically in Ohio and in Arkansas because of changes in payment policy. In the area of behavioral health and substance abuse, which drives a tremendous amount of costs and utilization in the healthcare system, we've seen reduced suicide for kids by getting the right care for them delivered to the right site by over 60%. Just focusing on behavioral health and substance abuse in Washington State and getting the right care coordination out, they reduced their high emergency department utilization by 23%. That's a huge number. That's a huge cost savings. Super utilizer programs in North Carolina, focusing on people getting discharged from hospitals, getting specialized care coordination to them, reduced readmissions by 20%. Again, you can't even start these kinds of conversations unless people have coverage. Medicaid is working, and this may be something to talk more about in the Q&A if you're interested. Medicaid is working to disseminate those kinds of innovations that I just spoke about that are developing at the state level to other states. We have set up an innovation accelerator program that's providing technical assistance to states and ultimately will be available to support enhanced data analytics, performance measurement, setting up groups of learning between different states. There are just tremendous, exciting things going on at the state level, and really what we want to do is facilitate states learning from one another. A couple of other big things going on at the federal level. We're developing new managed care rules for the first time in almost 20 years. Florida, as you know, has moved its Medicaid program almost entirely over to managed care. These are rules that are really about modernization and alignment with how other types of insurance are regulated, trying to enhance payment and accountability. And then in the long-term care area, as I mentioned, Medicaid is the largest source of payment in long-term care. We really drive a lot of what happens in long-term care. So this is a wonderful story. It's very true in Florida as well as nationally. 20 years ago, when you talked about Medicaid long-term care, you were generally talking about nursing homes. And now half the Medicaid dollar for long-term care goes to pay for care either in home or in a home-like setting. And way more than half in terms of the people who are getting served outside of nursing homes, which is generally where people prefer to get their care delivered. We also have a new regulation coming out that's really focused on defining what we call home and community-based services and making sure that those services are either in the home or in a truly home-like setting, and that they are safe, which is a particular challenge when you're delivering care outside of a more institutional setting. So next steps in Florida. The transition to managed care and Medicaid is really critical and something that we are trying to work closely with stakeholders in Florida and with ACA to make successful. As far as expanding coverage, we are very prepared whenever the state of Florida is ready to be flexible and to work with you on the best way to do it in Florida. Of course, we are eager to start that conversation, but whenever it happens, we'll be there. I mentioned the problem of dental care. I'm pleased to say that ACA is very aware of that and very engaged with us. There were recent changes in the managed care contract, which is hopefully something that will be a positive step in terms of getting access to dental care. And then the huge issue of provider payment reform. So on provider payment reform, as many of you know, last year we extended the LIP for a year with the explicit purpose of moving to a significantly reformed payment system. So this was a transitional year in which it was our collective responsibility to develop a system and develop a payment approach that can deliver quality healthcare services without the need for LIP funding. We required, and with the agreement of ACA, an independent report on the future of the LIP that would review payments and funding mechanisms and recommend reforms. And again, the obligation of that report was to lay out options without the LIP going forward. The findings of that report, which are under review, that report has been released, and I'm sure many of you have seen it in draft form. It will be finalized at the end of March. The findings of that report were that, first, that Florida's payment system is complicated, and far more so than payment systems in either Medicare or than payment systems in other states. That complexity leads to huge variation within the state in terms of the ratio of Medicaid payment to the cost of care. I think that was one of the most dramatic findings in the Navigant report, and certainly reflects one of the drivers of our push for that report, is that if you look across the state, that there are variations which do not appear to reflect any good policy rationale in terms of payment to cost. And finally, in terms of the options on reform to provider payment that were included at the end of the report, note that there were 4 options, 2 of which included Medicaid expansion, and that all the options including Medicaid expansion scored higher across the board than those that did not include expanded coverage. So I am going to pause here, and I would be happy to take any questions.
Dr. Fishman, appreciate your presentation this morning. So when you kind of lay out, it seems to me like you're laying out the challenges more so than what the actual next step is. And so what is your guidance for Florida in terms of the steps we have to take from where we are today to actually having the system that you kind of envision, or that CMS envisions for us to have a year from now or 5 years from now, or something along those lines? Since, I mean, as you know, hospitals are obviously reliant on those funds today. So.
What I'd say is there are models all around the country in terms of how to effectively pay for hospital services, both in Medicaid, and you can look to how Medicare pays for hospital services. And Florida has in place now, A, Medicaid managed care, and B, DRG-based payment, right? Both of those are at the heart of how many states pay for hospital services. So there are some key basic structural elements in place for us to build on, and that is the natural direction for us to work towards. But in terms of the specifics about how to get from point A to point B, that really remains to be negotiated. But what we're looking for is just kind of a basically equitable and rational payment system. We're not necessarily looking for something that is that conceptually difficult. Right? I understand that the getting from where Florida is now to that system is where a lot of the challenges lie. And the truth is, in terms of working that out, that's subject to negotiation, but it's really an area in which we need your all's input, and that's where it's critical for the people who know the Florida system to be responsible about it and take the language that I've emphasized here and that we've been communicating consistently for a year seriously to collectively for us to figure out how to get to point B.
You said you've seen an increase in state waivers. Can you tell us what kind of waivers you're seeing with the changes to healthcare right now?
Sure. I would say that the activity really falls into two main areas. One is states who are looking to tie expanded coverage to increased personal financial responsibility, individual skin in the game in terms of healthcare utilization. And that has taken the form in some states of premiums, in some states with different kinds of cost sharing. Those are all elements that require waivers of, in some cases, Medicaid statute. But there are areas that I think are really new and potentially innovative and potentially of great importance, not just for Medicaid, but for the whole healthcare system in terms of seeing what the impact of those kind of changes are. The other area that we're seeing a lot of state activity has to do with trying to change the way that providers are organized and paid in terms of linking different kinds of providers together to try to manage all the utilization that an individual is doing, building more regional kinds of provider organizations, and trying to pay on that basis also. That's something that in some states can be linked to managed care, right? Managed care can only go so far in terms of changing provider or organization. I think Florida has already done some of that in terms of having the provider service networks alongside managed care, but that's an area that also we're seeing a lot of really interesting and important state thinking. All right, well, if there are no more questions, I will be happy to stick around for a little while if there's any questions that people have afterwards. And thank you very much. Thank you to the AAF Foundation. And it has been a pleasure.